All right, so I welcome you all to this second day of the IPGS meeting, and we have a very exciting program today. We will be starting with the first session on AR syndrome, which is again very commonly seen, and I request the chairperson of this meeting, Dr. Vijaya, to say a few words and then invite the first speaker.
Good morning, everyone. It's a pleasure being in this meeting. I thoroughly enjoyed last evening's session, and it gives me a great pleasure in introducing our dear friend, Dr. Arif Khan, who is very popular among all pediatric groups in the country. He's a consultant pediatric ophthalmology and ocular genetics at Cleveland Clinic, Abu Dhabi, professor of ophthalmology, Cleveland Clinic, USA, and chair editorial committee, American Academy of Ophthalmology Basic and Clinical Science Course, Book 7, editorial board member of ophthalmic genetics, and clinical and research interest happens to be the management and genetics of ocular developmental disorders and strabismus. We are looking forward to listen to Arif Khan. Dr. Arif Khan, please.
Rahul.
Hello, everyone. Thanks again for having me. I always enjoyed these Indian Pediatric Glaucoma Society meetings, and I'm thrilled to attend and be part of the program. Once again, thanks for having me. I've been asked to speak about genetic testing for pediatric glaucoma, who, when, and how. So genetic testing isn't really just one test. There are many different ways to do genetic testing, and each of these different ways has different advantages and disadvantages. One aspect is, are we looking at sequence or are we looking at structure? These are two different types of analyses. Are we looking at one gene, multiple genes, the whole exome, or even the whole genome, which is becoming more popular in recent years? In addition to many different ways of testing, interpretation of the results can be tricky.
I think slides are not moving. Rahul, please check.
Rahul?
Yes, sir.
The slide is not moving, please.
We can't hear anything. Can you please check?
Rahul, can you begin? Can you start it from the beginning?
Even the screen is not coming properly.
There's a problem with Rahul's connection.
Yes, sir. Let me check, sir.
Should I take over?
Yes, sure,
Yes.
absolutely.
Let me see if I can share my screen. I cannot share my screen.
I think Rahul has stopped.
Oh. Okay, so you can see, can you see
Yes.
me?
Yes, we can. Yes.
All right, let's try it. There it is. No sound?
No sound.
There's a share sound. I see share screen. I don't see share. Yeah. Yeah. Oh, I see it. Yeah. Okay, let's try that. Start right there. And each of these different ways has different advantages and disadvantages. Yes? One aspect is, are we looking at sequence or are we looking at structure?
Yes, it's good
These
now.
are two different types of analyses. Are we looking at one gene, multiple genes, the whole exome, or even the whole genome, which is becoming more popular in recent years? In addition to many different ways of testing, interpretation of the results can be tricky. We can uncover variants of uncertain significance and more genes of uncertain significance when we're doing these whole genome analyses. The potential for incomplete penetrance or variable expressivity means that sometimes we have pathogenic variants in a gene in an individual, but that individual does not seem to show the disease that is running in the family. The potential for mosaicism means that you can have a pathogenic variant in a gene causing a phenotype, but that pathogenic variant is not detectable in the blood. Mosaicism is probably more common than is currently recognized. Bottom line, both genetic testing and interpretation of results can be tricky and should be done by someone or in concert with someone who has expertise. Now, there are many genes involved in anterior segment development, and therefore there are many different genes that can have pathogenic variants and lead to childhood glaucoma. It's not my goal to cover all of these potential genes, but I will refer to some of the major ones as we go through the presentation. With that background, now let's get into the main body of this presentation, genetic testing for our patients. Who, when, and how. Do we need genetic testing to diagnose and manage the childhood glaucoma that we see in our clinics? Bottom line answer, no. Diagnosis and management of childhood glaucoma is driven by phenotype. Decisions are driven by phenotype, not by genetic testing results. However, there are scenarios where genetic testing is very useful, and let's go through some of these. So the first scenario is when family counseling is desired and is reasonable. That is to say, reasonable from the pedigree. So here's a newborn Saudi girl with primary congenital glaucoma and a positive family history. The family is disturbed by recurrence of glaucoma among multiple relatives, and they want to understand what's going on and embark in genetic counseling to try to prevent it. This is very reasonable given the family history and particularly given the ethnicity, where it's highly likely we'll find a genetic cause. We look at the pedigree and we see that a sibling had congenital glaucoma, and interestingly, the father had juvenile glaucoma, not congenital glaucoma. Genetic testing for the affected girl reveals homozygosity for a known CYP1B1 pathogenic variant, and indeed the other affected family members carry the same homozygous variant. So in the father, it caused juvenile glaucoma rather than congenital glaucoma. This is variable expressivity for the pathogenic variant. Importantly, when we go on to test other family members, we find that some of them are homozygous for this variant, even though they didn't have congenital glaucoma. They later go on to develop glaucoma. This is an important service for the family known as Cascade Testing. Here's another example of Cascade Testing. The girl shown by the yellow arrow had primary congenital glaucoma. She's homozygous for a well-known pathogenic variant in Cpamd8 There are other family members who are known to have primary congenital glaucoma. But what's very interesting is these individuals highlighted by the red arrows. They didn't realize they had glaucoma because they didn't have primary congenital glaucoma, but Cascade Testing revealed they were homozygous for the pathogenic variant, and indeed they had undiagnosed juvenile glaucoma. This technique of cascade testing has also proven to be useful for large families with juvenile open-angle glaucoma from pathogenic myocilin variants. Let's move on now to the next scenario for genetic testing in childhood glaucoma. And that would be when the phenotype suggests a risk for actionable extraocular disease. Now, you can argue that you could follow the phenotype when you're suspecting extraocular disease without genetic testing, but really genetic testing is much more powerful because it can rule out those individuals who don't need that careful follow-up for extraocular disease. So here's a newborn who is referred as rule-out glaucoma, and we find that the child has classic aniridia. Classic aniridia is typically PAX6 related, and a newborn with classic aniridia from PAX6 pathogenic variant is at risk for Wilms tumor of the kidney if that pathogenic variant is a new deletion that's large enough to hit the neighboring gene WT1. This is really what I would consider one of the medical indications for genetic testing. We want to do copy number variation to make sure that this child doesn't have a large deletion that's hitting PAX6 and the neighboring gene WT1. And sure enough, unfortunately, this baby does have a large deletion on the short arm of chromosome 11, which includes not only PAX6, but its neighbor WT1. Goes on to develop Wilms tumor of the kidney the next year, but because the child was being followed carefully, it was managed appropriately and aggressively with minimum morbidity. It's important for us to recognize when aniridia, with or without glaucoma, is not a risk for Wilms tumor of the kidney. This baby has what I like to call partial aniridia with ectropion UVI, corneal haze from the glaucoma, and also an intrinsic corneal opacity that's from a central keratopathy independent of increased intraocular pressure. When I first started seeing these cases, I was testing them for PAX6 WT1 because I wasn't sure what's going on. But now I know this is a pathognomonic phenotype and is not associated with PAX6 pathogenic variation. It's actually specific for biallelic Cpamd8 pathogenic variants. There's absolutely no risk for Wilms tumor of the kidney. There's no risk for extraocular disease. Unfortunately, it is a very severe ocular phenotype, but at least there's no extraocular features that we have to worry about. Here's another newborn aniridia phenotype, a child newborn with congenital aniridia and congenital glaucoma. I now know that it's very unlikely, at least in my experience, for a child to have congenital glaucoma from PAX6 pathogenic variants. The glaucoma tends to be juvenile. Type of congenital aniridia with congenital glaucoma, I'm much more thinking about pathogenic variant in FOXC1. And sure enough, that's exactly what this baby had. She had a pathogenic variant in FOXC1. When she was a newborn, of course, she didn't have any teeth, but as she grew up, you can see the dental features that we associate with Axenfeld-Rieger spectrum. Axenfeld-Rieger spectrum confers a 50% chance of glaucoma and is often from pathogenic variants in PIDX2 or FOXC1. Most of the extraocular findings in this condition, when it's Axenfeld-Rieger syndrome, are not actionable, but there are exceptions. For example, you'd want to pick up sensory neural hearing loss or congenital heart defects in young babies. This is an interesting gene that's been associated with Axenfeld-Rieger syndrome-like findings that's come to light in recent years. This baby has anterior segment dysgenesis with glaucoma, as well as encephalomalacia. The encephalomalacia is from microvascular events. This baby had CLL4A1 related anterior segment dysgenesis. We now know that pathogenic variants in CLL4A1 can, in addition to leading to anterior segment dysgenesis with or without glaucoma, can lead to a microangiopathy of the brain or the kidney. Again, you can make the argument these patients could be followed very carefully clinically, these patients with anterior segment dysgenesis, but it's just more precise to have a genetic diagnosis to know what to potentially expect or not to expect as associated extraocular features. Okay, let's now move on to the third clinical scenario for genetic testing. And that would be when the glaucoma is in the setting of and related to systemic disease. So here's a girl with congenital glaucoma and has multiple congenital abnormalities and has craniofacial abnormalities as well. This doesn't really fit any known single gene disorder that I'm aware of. This is a great situation for doing a microarray because there's a suspicion of a large deletion or other copy number variation that is affecting this child. The findings of such analysis in this child are listed here. What's useful is looking at the genes that are in these abnormal regions to know what the child could be at risk for, and also to further research into causes of congenital glaucoma. Here's a child with glaucoma, but unlike the previous child, his distinctive facial and limb features suggest a particular gene and a particular diagnosis. Doing genetic testing to confirm the diagnosis molecularly confirms the risk for the specific extraocular features that are associated with problems in this gene. This 2-year-old boy has glaucoma in the setting of developmental delay and kidney disease. We really want to know what's going on here molecularly. When we do targeted testing of the gene suggested by the phenotype, we confirm the molecular diagnosis and confirm what the child is at risk for as far as other extraocular findings. Let's now move on to the final genetic testing scenario for childhood glaucoma. And that would be when the diagnosis is questionable in certain populations. Now, this is not common. I tried to highlight in the beginning that glaucoma is a clinical diagnosis and management is clinical. However, there are certain scenarios where genetic testing can be helpful one way or the other. This boy has been diagnosed and followed as megalocornea, but he has some clinical findings that are suspicious for glaucoma, although overtly he does not have glaucoma. It's useful to test him, especially given his ethnicity. And we confirmed that he does have homozygous pathogenic variants in CYP1B1. Very soon after the testing, his IOPs shot up into the 30s, and there certainly was no doubt he truly had glaucoma. This is an interesting case. This child with high measured intraocular pressure was actually referred to me as a fourth opinion. 3 previous ophthalmologists had told the family that the child needs emergency surgery. For reasons I won't go into, I diagnosed this child actually with CHED, congenital hereditary endothelial dystrophy, and saw no evidence for glaucoma. But it was very difficult for me to convince the family of this since I was in the minority opinion. Genetic testing is useful in this scenario. We can molecularly confirm the diagnosis of CHED, and the fact that this child does not have variants in CYP1B1 in a region of the world where CYP1B1 variants commonly underlie congenital glaucoma is supportive of the fact that there's no clinical evidence on my exam for congenital glaucoma, only for CHED. Let me end with this case. It's a sad case. When I first saw him, I thought that he had primary congenital glaucoma. But with more careful examination, I could see that he actually had intermittent pupillary block from zonular weakness and had a unique phenotype of primary megalocornea with zonular weakness and lens-related secondary glaucoma. This is a phenotype related to pathogenic variants in the gene LTBP2. For this condition, the lens has to come out. Angle surgery is disastrous for these patients. Unfortunately, the family did not like what I was telling them and didn't like the idea that I wanted to remove the lenses, even though I spent a lot of time discussing the situation. And the family decided to go elsewhere. Now, this unhappy face is not because the family decided to go elsewhere. It's because of what happened when they decided to go elsewhere. They were diagnosed and managed as primary congenital glaucoma, had angle surgeries with predictably very bad outcome. The family came back to me actually 2 years later in a very bad state. When I had seen him at 3 months old, there was no optic nerve cupping. The optic nerves were healthy, but in the 2-year interim related to these multiple surgeries, the child had severe cupping, severe loss of nerve fiber layer, and almost no vision. We did genetic testing when they returned, which confirmed, of course, the LTBP2 pathogenic variants. Had we done this testing in the very beginning, perhaps we could have convinced the family of the nature of the diagnosis and the need to remove the lenses from the beginning, and had a much better outcome for this child. This brings me to the end of my presentation, and I'd like to summarize. Genetic testing ordering and interpretation has pitfalls and requires some expertise. For the childhood glaucoma we see and manage in our clinics, we typically do not require genetic testing to diagnose and manage. However, as I've outlined, genetic testing is useful in certain scenarios. Once again, I'd like to thank the organizers for having me participate in this meeting, and I look forward to learning from the other presentations today. Thanks again.
Thank you very much, Professor Khan. I think that was a wonderful lecture. Do we have any comments?
We have a lot of questions, Dr. Khan. I don't know where to begin and how to. We will overshoot our times.
I better drink some water then.
Or can we have questions if we have at the end of the session? Can we finish the session and then probably have the questions?
All right. I think in that case, we can go to the next speaker. I think next speaker is Dr. Shikha. She is consultant at RP Center on Institute of Medical Sciences. And Dr. Shikha, you are there. And she will be talking on AR syndrome. the presentations and genotype and phenotype correlation. Dr. Shikha, please.
Yes, thank you so much, sir. Am I audible?
Yeah, you are audible, but the sound is volume is low.
Okay. Okay.
Maybe you have to speak a bit
I'll
louder,
try.
perhaps.
Okay,
Yeah.
I'll do try.
Please
So,
share your presentation.
yes. I'm having some problem in sharing my screen.
Rahul, can you please help her?
Yeah, I'm going to desktop here, share sound and optimize for video clip. When I press share, it's asking, allow Zoom to share your screen. I'm going to open system preferences here. And yes. Yes.
You have to go to privacy settings and click Zoom.
It's not getting clicked here. It's not getting.
You have to unlock first. Unlock with your password, then click the Zoom in the privacy settings. Then it will allow.
Okay, Shikha, we can have some questions from Dr. Arif. Till then, you can you get some time to work on that. Dr. Arif, there are a lot of questions here, I think, on the chat box.
Okay, shall I open that? Okay. Do LTBB2 variants not have angle abnormality? Oh, that's a big discussion. Let me just see. You know, CYP1B1 was the gene that was first associated with primary congenital glaucoma. And for a very long time, that was the only gene associated with primary congenital glaucoma. Then there were two papers that came out almost at the same time describing a second gene for primary congenital glaucoma in a few families from Iran, Pakistan, and some Roma gypsies also. And in these families, there were LTBB2 variants detected, and these patients had been diagnosed as primary congenital glaucoma. But in fact, these patients were phenotyped as adults and had end-stage phenotypes, and many of them had had very poor results from angle surgeries. Many of them had subluxated lenses or were aphakic because the lenses had to be removed. In retrospect, and I've spoken to these authors also, those patients never had primary congenital glaucoma. Those patients had a primary megalocornea with zonular weakness and a secondary lens-related glaucoma, which is related to the lens bouncing forward. And, you know, when you see the adult as an end-stage phenotype, I can understand why you would assume that the patient might have had primary congenital glaucoma as a child. But when you see these children as children, when they first present, if you examine them carefully, you see that the megalocornea is primary. It's not from increased intraocular pressure, and the zonules are weak, and there's actually an angle closure glaucoma. All of the studies of mice, experimental studies, when they do LTBB2 knockouts, the trabecular meshwork is normal. Most of the centers throughout the world who have looked at their CYP1B1 negative primary congenital glaucoma patients, most of them cannot find any LTBB2 variants in patients who are very carefully phenotyped as primary congenital glaucoma. Now, there is a report here or there that reports, you know, primary congenital glaucoma with LTBB2 variant. So I'm not going to say that it doesn't exist, but I've never seen it. And I think it's much more likely that if you have LTBB2 variants, you're dealing with this phenotype of primary megalocornea with zonular weakness and lens-related glaucoma that can be mistaken as primary congenital glaucoma. The big clue is these corneas are usually 14 millimeters, and there's no Hape stria. There's no Hape stria. So I think I probably took all the time with that one question.
So should the lenses be removed in all?
They have to be removed.
Okay.
They have to be removed. The lens is the problem. And the patients who I've had who've come to me and we will remove the lens, they do fine. But the patients who are, bounced around and say, let's watch and let's wait, or they have angle surgery, they start to get angle problems, and they start to get angle closure, and they can get glaucoma. So, yeah, this is one of my favorite topics, actually, right up there with the congenital ectropia uvei glaucoma, neonatal glaucoma. So we see a lot of those cases here in the region, and I know you see them in India as well.
Yes.
We want to get that message out there. Of course, in a busy glaucoma clinic, you see a child with high pressure and big corneas. Of course, it's easy to just put them on the list, but we have to keep this in mind. And the big clue is they don't have any Hapestria, because there's no way a baby is going to have a 14 millimeter cornea from increased intraocular pressure without a Hapestria. It just wouldn't happen.
Dr. Khan, we've been seeing a lot of these BP2 variants in children and even juveniles with absolutely normal anterior chamber depth and absolutely normal corneas and absolutely normal lenses. I mean, so I don't know what.
Well, there's a different. That's what it's. I like the word you used, variant. When you have a mutation in the gene and it's affecting the function severely of the protein, this is the phenotype you get, what I'm talking about, the primary megalocornea, zonular weakness. Now, variants, if it's not, knocking out, there could be a role for LTBB2 in even primary congenital glaucoma as a variant in concert with other variants in the genome. So that's why we like to use the word variant most of the time. But when you knock it out, when you really disrupt the protein, there's no question this is the phenotype you get. But maybe variants in the gene could contribute to other phenotypes.
Dr. Shikha, are you ready?
Dr. Arif,
Dr. Shikha, are you ready?
okay.
So thank you, IPGS, for having me here. Thank you, Professor Vanessa and Dr. Sushmita ma'am. And it was an excellent lecture by Professor Khan, sir. And I'm just we are just trying to do genotype-phenotype correlation in Axenfeld-Rieger syndrome. And we have just started it. So we have done one cohort. I'll be sharing my results for that. So we all know that Axenfeld-Rieger syndrome is a clinically and genetically heterogeneous group of developmental disorders, which affect primarily the anterior segment of the eye, often leading to secondary glaucoma. The major genes that have been found so far in Axenfeld-Rieger syndrome, they include PTX2, FOXC1, and PAX6. Literature till now suggests an autosomal dominant inheritance with complete penetrance in cases of ARS. However, we have been able to identify FOXC1 mutation in approximately 2% of our ARS patients, and most of our ARS cases have both parents unaffected, hence refuting autosomal dominant kind of inheritance. Further, we all know that ARS, the sine qua non characteristics of ARS, they include a posterior embryotoxon with or without presence of iris adhesions much higher up, above the level of the trabecular meshwork, even up to the Schwalbe line or even further above. But we have been seeing some atypical ARS cases which have some iris characteristics of ARS, but without any of these two characteristic feature of ARS, which has also been described by Professor Khan here. So this was a cross-sectional observational study in which we recruited previously diagnosed atypical ARS patients with glaucoma who were following up with us. And they had none of the characteristics of posterior embryotoxon or iris adhesions. After obtaining informed consent, we took trio blood sampling for whole exome sequencing and processed the blood sampling. So the inclusion criteria were they had to be more than 8 years of age so that we could strictly phenotype them with no family, with or without any family history of glaucoma, and ability to participate with consent. Cases with poor fixation, poor visual acuity, nystagmus, uncooperative patients, causes other than ARS were excluded. So we did a strict phenotyping, including examination like visual acuity, slit-line biomicroscopy, clinical photograph, gonoscopy, ASOCT, fundus examination, IOPs, and whole exome sequencing was performed. So of the 50 patients that we saw with clinical features of ARS, 5 of them were identified with characteristics so labeled as atypical ARS, with no evidence of presence of either a posterior endotoxin or tissue strands in the angle. Characteristically, all of these had bilateral neonatal severe glaucoma with typical iris abnormalities like correctopia and iris atrophy, which are suggestive of Rigger's syndrome. The iris atrophy was characteristically peripheral and sectoral. So these are the clinical features of the 5 patients. So we can see that there was some kind of iris atrophy in the periphery, leading to either the presence of posterior pigmented epithelium that was evident, leading to a brownish color, variegated appearance, or polychoria formation in the eyes. Here also we can see a small stretch hole. There was also some kind of spiraling of the pupil with the whirling appearance that was present. In patient number 3, we can see a large correctopic pupil with the presence of ectropia on UVA and stretch hole and iris hypoplasia. Again, this patient had some kind of spiraling of the pupil with peripheral hypopigmentation. And here also we can see characteristic correctopia with upward slanting pupil and peripheral depigmentation of the iris. Patients 2, 3, and 5 also had evidence of telecanthus. And unlike oligodentia that is characteristic of ARS, they had some other dental anomalies like anterior crowding, crossbite, and dental caries, and edentulous teeth. On ASOCT, these are spectralis pictures, and this is one of that of Cassia. None of these had evidence of iris adhesions or a posterior endotoxin, but a dysgenetic angle was visible with the presence of a membrane suggestive of trabecular dysgenesis. So all of them had onset of glaucoma at birth. Now they were older in age at the time of examination. The corneal diameters was highly exaggerated to the tune of 16 millimeters in patient number 4. CCT was almost normal except patient 4 again, who had highly some thickened cornea. The eyeballs were stretched, leading to increased axial length, and it was up to the tune of 29 millimeters, suggestive of ophthalmic features, except for patient 5 who had in the borderline range of axial length. Half striae was seen in patient 1 and 2. None of them had posterior endotoxin or high pass. All of them had correctopia. Polychoria was present in 3 of them, and iris atrophy was seen in all of them. Iris whirling that I discussed was seen in 3 of the patients with some kind of systemic facial and dental features. On genetic testing, we could find that all the 5 patients had biallelic mutations in the Cpamd8 gene. So this was a homozygous mutation in the Cpamd8 gene in patient number 1, whereas all others had heterozygous mutations in different genes, leading to a biallelic variant. Patient number 2 also had mutations in Cpamd8 gene and CHRDL1 gene, and patient number 3 had a heterozygous mutation in FOXC1, which was of uncertain significance. So clinically, there is a need for universal definition of ARS because till now the definition suggests that posterior endotoxin and iris adhesions are required. Probably a kind of definition which suggests that it is a bilateral developmental disorder with hyperproliferation or contraction at one or more sites, for example, angle, or iris. If it is at an angle, it may produce features such as posterior endotoxin or iris tissue strands at the angle. If it is at the iris only, it may produce only the iris atrophic changes that we see, with or without non-ocular developmental anomalies with glaucoma. So there have been reports of atypical ARS in the past also, where posterior endotoxin has been suggested to may not be a first part of diagnosis of Axenfeld-Rieger syndrome. So when we look at the genetics of ARS and Cpamd8, we all know that Cpamd8 is basically a common cause of PCG, and sometimes it has also been reported to be a part of anterior segment dysgenesis, including cases of Peters anomaly, aniridia, and lately neonatal form of CEU. So Cpamd8 gene, we know that especially in our continent can produce a lot of phenotypic heterogeneity in the terms of manifestation. Also, ARS is now supposed to be a result of a lot of genotypic heterogeneity, not only the major genes that we have seen so far, Cpamd8 can also be involved. Cpamd8 has been reported in ARS in heterozygous fashion, but rarely as pathogenic variant. Professor Khan here also had reported a case of neonatal glaucoma with normal iris in the beginning, but progressive iris depigmentation and atrophy at 5 years. And this patient also harbored Cpamd8, and he also labeled this patient as a case of atypical ARS. So in ARS, there is a possibility that maybe FOXC1 and PTX2 lead to a later onset of glaucoma, whereas Cpamd8 presents as neonatal glaucoma, but it needs further credence. So congenital glaucoma, when it presents with corneal edema, it is very difficult for us to examine properly because we may not be able to do gonioscopy or look at the iris features so prominently. And therefore, it is a must for the clinicians to go back and do the EUAs repeatedly later on when the cornea clears and as the child is growing to exactly try and phenotype what the patient is presenting with. So there is a question now that should neonatal glaucoma be looked as a separate entity in itself, irrespective of iris anomalies. This paper, again, this was from Professor Khan, sir, where he just did genotyping in all the neonatal glaucomas that he was seeing. And he found that irrespective of the iris anomalies, Cpamd8 mutation were found in 91% of the congenital glaucomas that he saw. And newborn glaucoma in the Arabian Peninsula is typically Cpamd8 related, even in the setting of iris abnormality. Similarly, a paper by Sushmita Kaushik ma'am recently says that even the neonatal onset congenital ectropia and uvea may be caused by Cpamd8. So maybe we should look at neonatal glaucoma as a separate cohort, and most of these cases could be actually related to the Cpamd8 gene. Coming on to Cpamd8 mutations and anterior segment dysgenesis, there are two reports, one from the Australian continent and one from the American one. And it says that when they looked at biallelic Cpamd mutations, they found that in approximately 6% of congenital glaucoma, they could find these mutations. And again, these kind of congenital glaucoma, this picture is from this paper, was mainly anterior segment dysgenesis with kind of correctopia or iris abnormalities and ectropia and uvea in these cases, like the ones we suggested, but they've not labeled them as ARS cases. Similarly, this paper also suggests that mutations in Cpamd can lead to unique form of anterior segment dysgenesis. Again, this is a case with ectropion and correctopia and polychoria here. So Cpamd8 mutation could also be related to Axenfeld-Rieger syndrome, like seen in our cases. So to conclude, unlike typical ARS, which carries FOXC1 and PTX2 mutations, atypical ARS can also harbor Cpamd8 mutations. And patients with atypical ARS can present as neonatal glaucoma. And these patients should need to be screened for mutations in the Cpamd8 gene. There is a possibility that presence of Cpamd8 mutation may make these cases more severe, such that all these presented with exaggerated corneal diameters, greatly stretched axial lengths, and high pressure in the neonatal glaucoma itself. Presence of buophthalmos and neonatal glaucoma with HARP striae probably make them overlap with PCG clinically as well as genetically. And the overlap of Cpamd8 mutations with Cpamd8 and CHRDL1 needs to be further investigated. This is on the lighter side. And here, Professor Vinay sir, who has been guiding us, and he's a great motivator. He himself is such a hard worker, and he keeps asking us questions that helps us to keep working further. Thank you so much for your patient listening.
Thank you, Dr. Shikha, for excellent presentation. Next talk is on AR syndrome surgical options by Dr. Sirisha. While Dr. Shishai is uploading her slides, I think Dr. Vijay was saying something before we cut off. Dr. Vijay, you had some comments.
No, I think I missed it now. Sorry.
Right. I thought you were asking something. So
no, I was. It's okay.
All right. So we'll go to the next talk. Dr. Sirisha, please.
Hi, friends. So I'll be discussing the surgical options that are there in the management of Axenfeld-Rieger syndrome. As we know, this is a rare autosomal dominant disease characterized by abnormal iridogonio-dysgenesis or iridocorneal adhesions in several of these patients. More than 50% of these children develop glaucoma, and close to 2/3 of these patients actually require a surgery for control of intraocular pressure. The various features that are present in them is shown here. Prominent Schwalb's line is a very important feature in these patients, and sometimes you also see detached Schwalb's line that can be freely floating in the anterior chamber or found adherent to the iris processes. Iridocorneal adhesion is a major problem in these eyes, and sometimes they can be very broad, and the extensive pass can make the anterior chamber very shallow. Keratoconus is a problem, and corneal edema can also be associated, apart from the non-ocular involvement in some of these syndromic children. Surgical management includes several of these procedures. We will just go through a few of them to understand how to choose the procedure and which procedure works best in these children. I think one has to take into account the age of presentation of the disease, the anterior segment features, how severe the iridocorneal adhesions are, presence or absence of corneal edema, corneal scarring, keratoconus. All of these features have to be taken into account before one decides on an appropriate procedure, and surgeon's expertise is also very important. Because of extensive iridocorneal adhesions that these children have, angle-based procedures become technically very difficult. The angle structures could be very abnormal, and the studies have shown poor results with goniotomy in children with Axenfeld-Rieger syndrome. We combine trabeculotomy and trabeculectomy is the procedure that we commonly perform in these patients. This procedure is similar to that of procedure that we normally do in a primary congenital glaucoma, except a few features that one needs to remember. So like we discussed, the extensive iridocorneal adhesions are definitely something that one needs to be careful about. Identification of Schlemm's canal can sometimes be difficult. If we are able to identify it appropriately, then a combined trabeculotomy and trabeculectomy can easily be performed. While performing an ab interno trabeculotomy, care should be taken to prevent damage to the iris and corneal structures because of the iridocorneal adhesion. One needs to be very gentle when trying to perform the ab interno trabeculotomy. And the trabeculectomy is completed the way we normally do. There was a baby who was 1 day old, born to a mother who had Axenfeld-Rieger syndrome, was brought to us to the emergency, and we performed a surgery at the age of 2 weeks for this child. A combined trabeculotomy and trabeculectomy was performed. We don't have the intraoperative pictures, but you can see the 6-month post-operative picture showing clear cornea in the right eye with peripheral iridocorneal adhesions, and in the left eye showing a central scarring with the peripheral iridocorneal adhesions and prominent Schwalb's line in both the eyes. This child had a very high refractive error, high hyperopia and astigmatism, and nystagmus as well. So over a 8-year post-operative review, the pressures were very well controlled, and the best corrected visual acuity was 20/60 in the right eye and 20/100 in the left eye due to the presence of a corneal scar and amblyopia. So the outcomes of combined trabeculotomy and trabeculectomy were published from our institute by Dr. Mandal et al., where early onset Axenfeld-Rieger anomaly were treated with combined trabeculotomy and trabeculectomy with a mean follow-up period of 5 years. And they found that both the complete success and qualified success was quite good at 5 years, and it was moderate at around 10 years. Please note that some of these children where the Schlemm's canal identification was not possible underwent trabeculectomy alone. So sometimes it may not be easy to identify the Schlemm's canal because of the maldevelopment or extensive adhesions that are present. So this is one such patient where it was not possible to identify the Schlemm's canal despite the dissection in the appropriate position, as well as actually visualizing the aqueous droplet that was kind of oozing from the area of the Schlemm's canal. So we decided that since we were not able to perform a trabeculotomy, we went ahead and did an ostium to continue the trabeculectomy. But through the base of the Schlemm's canal that we could identify, we actually completed the trabeculotomy as well. So sometimes we can try and modify the procedures in such a way that once the deep block is excised before doing an iridectomy, if we are able to, if your location is appropriate, if you're able to identify the base of the Schlemm's canal, we can also perform a trabeculotomy even after removing the deep ostium. Certain other modifications that we advocate are since these children also have keratoconus. This was once a child who had displays pupil very inferiorly, and child had a chin up position as well. So we performed a pupilloplasty to also visually rehabilitate the child during the performance of trabeculectomy. Since surgically the failure is not uncommon in these patients, repeat trabeculectomy is a procedure that we choose as well. And while performing a repeat trabeculectomy, we always use mitomycin C, and several of them actually used mitomycin for the first procedure also. But for us, it depends upon the age at which we operate. If we are operating on a child who is very young, early onset or neonatal onset type of glaucoma in these children, we don't use mitomycin C, but for a repeat procedure, mitomycin C is always advocated. In some difficult situation, either if the surgery, primary surgery fails, or if the anterior segment dysgenesis is very severe, that is precluding future keratoplasty, then an implant is a choice, and we perform Ahmed glaucoma valve implantation in these children. Technically, it is similar, except the fact that because of these extensive iridocorneal adhesions, one needs to be very careful in placing the tube in the anterior chamber to prevent the tube block as well as damage to the adhesions that are there and damage to the cornea. In some situations where the disease is very severe or they present late, and the picture that you see, where you see that the limbus is extensively stretched, and if they have a poor visual prognosis, then we tend to perform a transcranial cyclophotocoagulation. So there was a recent publication from Zepeda et al. Who looked at the surgical outcomes of various glaucoma procedures used in the management of Axenfeld-Rieger syndrome. Although the sample size was not large, they had a mean follow-up of 5.4 years. In their study, they found that the trabeculectomy with antifibrotic agents had better success rate compared to combined trabeculotomy with trabeculectomy. And goniotomy was performed in lesser number of eyes, but they had a significant success. It's also possible that less severe disease and less severe iridocorneal problem eyes possibly had a goniotomy in their series. They also evaluated a few eyes where Ahmed implant as well as Bavelt implant was performed, and cycloablation as well. And they found that Bavelt did better than Ahmed in their cohort. Encystment of the bleb is not uncommon in these patients at all. They actually develop a very, very thick cystic encysted bleb, and I've had a couple of patients for whom by about third to fourth week, because of huge encysted blebs, we had to start them on aquasuppressants and treat them like any other encysted bleb. And typically by a couple of months, the bleb wall becomes thinner and the trabeculectomy functions better. Progressive peripheral anterior synechia and failure of procedure and corneal decompensation is not uncommon in these children, and hence follow-up becomes very, very important. So to summarize, Axenfeld-Rieger syndrome is a difficult glaucoma to treat. Surgery is the choice in several of these patients. It's very important, although we have so many procedures that are available, choose an appropriate procedure based on the situations that we describe, the age of the patient, how severe the anterior segment dysgenesis is, associated ocular anomalies as well, and also have to have a very good follow-up in the long term because of the fact that their primary surgeries can fail, and also the additional complications like corneal decompensation that can occur in these children over a period of time. One word that we should remember is these children are bound to have severe amblyopia because of the way the corneal changes are. So appropriate refractive correction and amblyopia management goes a long way in helping these children see better.
Thank you, Dr. Sirisha. I think you did a wonderful job taking us through the surgical options for AR syndrome. We'll take the questions after the last talk. And the next talk is AR syndrome long-term outcomes. And the speaker is Dr. Mandal. Dr. Anil Mandal is also the president of the IEPGS. Dr. Mandal, please.
Thank you. Let me present my part, long-term surgical outcome. Some of the presentations or slides shown by Dr. Sirisha, I'll repeat the similar findings. You know, this is a patient who presented with congenital onset Axenfeld-Rieger anomaly. This is Rieger's anomaly with dental abnormality. All these points have been highlighted very well It's usually a bilateral disease, and there is no sex predilection. This is the artist diagram showing the abnormalities in an eye with axon-filled rigor anomaly. Almost 50% of the patient will have glaucoma. It may present at birth or any time after birth. When the patient presents at birth, probably the mechanism is same as that we see in primary congenital glaucoma, high insertion of the anterior uvea in the posterior meshwork. Now the question is, goniotomy is, which is classic surgery for primary congenital glaucoma, is usually very difficult even if the corneal clarity permits, because of the iridocorneal additions we see typically in axon-filled rigor anomaly. The goniotomy results, as reported by Rice in 1977, extremely poor, to the extent that he commented goniotomy is probably contraindicated in axon-filled anomaly. Dr. Walton did surgery goniotomy. 2 out of 5 patients of iridocorneal dysgenesis were successful. Field analyzing the basis of development of glaucoma realized that probably angle surgery is not the way to go. Trabeculectomy, possibly with antimetabolite, is the ideal surgical technique. The problem of goniotomy or trabeculotomy is associated with the presence of iridocorneal additions, the typical abnormality you see here in the artist diagram. Compared to goniotomy, external trabeculotomy is still a possibility, because if you can really, from external dissection, if you can identify this lens canal, you probably do the trabeculotomy part. The iridocorneal stretch, iridocorneal addition may be stretched, and there may be a stretched appearance of this valvage line like this, as you can see here in this picture. Wallace reported intersegment dysgenesis. 9 of 13 eyes achieved stabilization of disc appearance, and trabeculectomy with mitomy is the way to go according to his choice. Now, I'll say trabeculotomy with trabeculectomy, because the question is a significant percentage of cases compared to primary congenital glaucoma, there may be abnormality in the Slem's canal and the post-canalicular outflow channel, maldevelopment. Considering that as the anomaly, in a case of axon-filled rigor anomaly, combining trabeculotomy with trabeculectomy gives better result. Here at the end of trabeculectomy part is completed, and we suture the superficial scleral flap using only one suture at the scleral flap apex using 10-nylon suture. This paper was highlighted by Dr. Sirisa also. Over a period of 20 years, 1991 to 2010, 44 eyes 44 eyes were included in this. 20 patients had bilateral affliction. Only 4 patients had unilateral affliction. Mean age at surgery was 2.5 months. That is, most of the patients belong to congenital onset or early infantile onset glaucoma. We included patient up to 3 years of age. Only 1 patient was having clear cornea. Rest of the patients were having corneal edema at presentation. The success rate we see here. The success rate of 93% was maintained till 5 years of follow-up, and then decreased gradually at the end of 10th year. Success rate without any medication reduced to approximately 42%. Now, when we added 1 anti-glaucoma medication in the form of timolol maleate or 2 medication in the combination of timolol and dorzolamide, the success rate again improved significantly. Compared to primary congenital glaucoma, combined TRAB and TRAB results versus the similar surgery in axon-filled rigor anomaly, my impression is some of the patients will require anti-glaucoma medication supplementation to really have good pressure control. These are the photographs included in the paper, right eye and left eye preoperative versus postoperative appearance, and the bleb appearance you can see here. This is preoperative versus 1 year postoperative appearance of the cornea, showing corneal edema clearance totally. This is the pre-op versus 1 year postoperative appearance of the left eye, and this is the 3-year bleb appearance. You can see the right eye and left eye, both the eyes bleb appearance satisfactory. We do not use antimetabolite in the primary surgery because of my obvious choice, and the appearance of the bleb is such that even if later on conjunctivitis happens, these blebs are very protective. Infection doesn't travel into the intraocular space. From that point of view, if you use mitomycin, you should be very careful. Mitomycin treated bleb are very prone for infection and transferring the infection from the external surface to the intraocular structure. As we told, axon-filled rigor anomaly is a diverse clinical entity. I'll give this example of this family. This child was brought to us after birth at the age of 2 weeks, immediately after birth. And when we examined the child, we realized that the child is having congenital onset axon-filled rigor anomaly with glaucoma. Immediately, we looked at the eye of the mother. Mother has axon-filled rigor anomaly also. We inquired, this is the second child, what about the first child? The mother replied, the first child is perfectly normal. We said, but we want to see the child. I'll come to this story later. The child was having congenital onset glaucoma. After 6 months of birth, combined trabeculotomy, trabeculectomy, the child had severe injury to the eye while at play, and we lost the eye, the right eye, and the left eye is doing. Here is the preoperative appearance of the eye, right eye versus left eye. You can see the swell base line, and you can see how the swell base line has detached from the periphery towards the center of the. This is the appearance. The eye became bicycle after injury. This is the appearance after a few years of surgery. You can see the swell base line lying here. This is the preoperative versus postoperative appearance of the left eye, which is the only eye now. The bleb appearance is satisfactory. We have not used anti-metabolite in the primary surgery. This is the disc appearance of the eye. This is the field charting, showing good visual field for the left eye. Now, we examined the first child. The first child has onset glaucoma. And this is the clinical appearance of the right eye and the left eye. Intraocular pressure was borderline. We supplemented with medical therapy. We followed up the patient for some time and then realized the child it's better to go for surgical intervention. Combined trabeculotomy, trabeculectomy without any antimetabolite was used. Right eye followed by the left eye. And that is the bleb appearance of the both eyes and intersegment OCT picture showing clinical picture of the gonioscopic abnormality as we see in OCT picture. This is the fundus appearance, the disc appearance of the child. This is the field Humphrey visual field result, right eye versus left eye. Here is the mother. The mother had this kind of appearance, right eye and left eye, very severe abnormality of the anterior segment. But fortunately, the optic disc was healthy and the mother was having normal intraocular pressure. We followed up the mother for a long time. And later on, patient developed borderline higher pressure on topical anti-glaucoma medication. The pressure is under control, and the mother here completed about 15 years of follow-up. You can see the severe gonio anomaly. Very interesting. Severe gonio anomaly in the mother, still very well controlled pressure with one anti-glaucoma medication. The first child was having juvenile onset glaucoma, and the second child was having congenital onset glaucoma. Here is the ASOCT picture of the mother showing the appearance of the right eye and the left eye. This is the disc appearance of the mother, and mother is on one topical anti-glaucoma medication. Pressure is very well controlled and is in regular follow-up. So to really conclude, axon field rigor anomaly is a very interesting disease with diverse clinical manifestation. Glaucoma, in spite of difficult clinical appearance, glaucoma may not be there. Lifelong follow-up is required to detect the glaucoma at its earliest stage and then management. It can present as juvenile onset and even at infantile onset or neonatal onset glaucoma, and the management should be planned accordingly. In the early stage, particularly neonatal onset and infantile onset glaucoma, surgical treatment should be done, and I believe if there is corneal edema, it should be done as early as possible. If the cornea is clear, probably you can assess the situation and plan medical treatment to start with, and then plan about the surgical treatment if it is required. Just to conclude this statement, compared to primary congenital glaucoma, early onset glaucoma in axon field rigor anomaly, the success rate of surgical intervention is probably little lower, and some of the children will ultimately require supplementation with medical therapy in the long run. In any case, lifelong follow-up is required. With this, I conclude my talk. Thank you.
Thank you, Dr. Mandal. I think for your excellent presentation, and we have been seeing your surgical results always so good and fantastic. We have some time for the questions. I think Dr. Viren, can you skim through the question? I can see one with Dr. Sushmita. She says the superior subluxation of the lenses can be seen in NRID also, which is associated with PAX6. And also, I think Arif mentioned about the zonular laxity in LTBP2. Are these two phenotypes different, and are their outcomes different? Dr. Arif, can you maybe shed some light on this?
Thank you. I answered it a little bit in the chat. They're very different. In the LTBP2 mutations, actually the zonules are fragmented, and they're, it's just because babies have a very formed vitreous, the lens doesn't go anywhere, and it tends to go anteriorly. But in PAX6 mutations, you do have zonular weakness, and sometimes you do have lens subluxation, which is part of classic aniridia, but it's not a prominent feature. It's not common, but it definitely happens. So the difference is that in PAX6 mutations, you can have zonular weakness and lens subluxation uncommonly, but in LTBP2 mutations, it's very common, and LTBP2 is actually a component of the zonules. It's responsible for zonular maintenance. So that's why it's such a prominent feature in that.
And functionally outcome-wise, I mean, would there be any differences?
In terms of, well, I mean, in aniridia, classic aniridia, it's typically not a big issue. It happens. It can be part of the phenotype, but it tends to be partial and not so significant. Whereas in LTBP2, it's very significant. It's all of the zonules are fragmented, and very often in some of these patients, they don't have surgery, and as they get older, and they don't have that bad glaucoma, they have intermittent pupillary block. As they get older, the lens falls back because the zonules are really almost completely fragmented. It's almost like homocystinuria. Although homocystinuria is different, the weakness in the zonules comes later from the metabolic environment. This is a congenital abnormality, the zonules.
I think once the lens is out, the pathology is taken care and they do very well. There is no
you're talking about the outcome of the glaucoma. Yes. I mean, if you take the lens out, that's it. That's why and unfortunately, I find it sometimes the families don't understand this, as the case I explained, but definitely the families where there's a large family and there are multiple people affected, they come and asking for the lenses to be taken out from the babies, even if they don't have the disease, because they know what happens. Some remote area and the lens they have a severe pupillary block. Sometimes the lens comes into the anterior chamber. When that happens, actually, it's no question. Everyone understands the lens has to come out. But the problem is when it's just causing this intermittent pupillary block.
Yeah, can I just share a couple of patients that we had seen some time ago? In fact, they were lost for follow-up for a few years. And when they brought the child, a girl and a boy, both from the same family. So the girl was blind in one eye with an anterior subluxation and almost had a deformed globe. And the boy now had a posterior dislocation, bilateral spontaneous posterior dislocation. And the third child actually was only 1.5 years old, had severe phacomatosis, but did not have any dislocation as yet. So now the first child, obviously the girl, we could not save one eye. The second eye, we did a lensectomy. Now the third child, the youngest one, we've done a prophylactic lensectomy. And so this is typically what we see consanguineous marriage again. But we do not know. We've asked for a genetic testing, but seeing the first and the second child, the parents willingly agreed to have the youngest one to be operated. Otherwise, they were not willing. Even for the second child who had a posterior dislocation, they were not willing for a surgery. So like you said, once they see the family go through it, they know that they cannot wait anymore. And the third child, the youngest one, did not have glaucoma as yet, but the first two children had. So like you rightly said, they have highly myopic eyes, huge corneas, but no HAP striae. Typically, they don't have a HAP striae, despite the eyes look really large. So this was thanks to Dr. Arif Khan.
Stories are there plenty to share. The first child was managed with the angle surgery, and later they ended up with the lensectomy, almost blind with so much of damage. Second child had problem. They came to us and we felt that it's a pupillary block that is the cause for the glaucoma. So it took time to convince. Once the lens are out, the child is doing extremely well. So you can see a gross difference between appropriate diagnosis and management and managing the angle as a congenital glaucoma. So what a difference it makes. I think this has to be, only problem is we have not done the genetic analysis. So
you don't need to do genetic analysis. It's a very specific phenotype.
Yes.
If I see that phenotype, I know what it is. But in the case that I showed in my presentation, perhaps if we did genetic analysis, that would have helped convince the family. I don't know. But I wouldn't say you need to do genetic analysis to make that diagnosis. It's very characteristic.
So can I ask something?
Yes, go ahead. I had so many comments for Dr. Sheikha, but I'll try to hold back.
So I wanted to know what's the take of IPGS senior members about prophylactic lensectomies in these kids who are coming with normal IOPs and normal fundus with megalocornea and some kind of zonulopathy. So they are all right now, but we know at some point of time they will present with either anterior subluxation causing loss of vision or posterior dislocation, like Dr. Senthil ma'am just mentioned. So should we actually look at now for doing prophylactic lensectomies in these child and rehabilitate them before something happens to them, or should we wait and watch? Because we know that the patients in our scenario don't usually follow up so keenly and may present with vision loss in one eye, and then we're left with the choice of treating only the second eye now. So what's your opinion?
Yeah, if I can just add, I don't think it's prophylactic, it's therapeutic, because the lens is an issue, zonules are a problem. Removing it actually helps, like what we had just discussed. So I think it's not a prophylactic lensectomy. I would look at it as a therapeutic, that's the way you manage these eyes.
We have to give an appropriate diagnosis. There should be associated megalocornea. Yeah. And we should prove this is the cause. Then this, Dr. Arif has beautifully mentioned, because it is intact vitreous does not allow the lens to go backwards. So it will keep coming forwards. Once you prove that, I think the lens has to be out. Otherwise, child will develop pupillary block. Then you can have the secondary features, even including the HAP striae, because acute rise in the pressure happens.
So these patients may have good BCVA also, like with glasses, they will be like 6.6 and N6.
Unlikely. It will keep changing because the lens is not stable. Yes. Unlikely, they will have good visual acuity.
So would you confirm the diagnosis with, on a molecular level, like LTBP2 mutation, or based on the phenotype only you can take that decision?
I have no problem just on the phenotype. It's such a clear phenotype. This is not subtle megalocornea. These corneas are 14 millimeters. They're not, it's not a question. And they're having intermittent pupillary block. Actually, if you take these patients, you can even just lie them on their stomach if they're sleeping and open their eyes. You see the iris tenting.
like a pyramid from the lens moving forward. It's positional. The lens is just sitting there. It's not, this is a rare condition. I'm not saying that every patient with megalocornea has this. You know, this is a rare condition, but when you see it, I would say the lens has to come out.
And when the glaucoma happens, what is the best thing to do then? We combine it with a trabeculectomy? I mean, if we had this thing, what do we, or we do put in a tube, or?
These patients have to be made aphakic, and I would be consider a ECP personally.
Okay.
They have, because they have to be made aphakic. The lens has to come out.
Yes, and then what about once the glaucoma has set in? With it.
I like ECP.
Okay.
I like ECP for this.
Sirisha, what would you do? A tube or something?
Yeah.
A
So
tube along with
couple of children, correct. Lensectomy first. Majority of them settle down with additional medical management. If pressures go uncontrolled, then it is a tube.
There are a lot of questions. Actually, I think we have already, exceeded the time by a couple of minutes. I request the chairperson to make concluding remarks and close the session, please.
Thank you very much for the wonderful session, and thoroughly enjoyed and very thought-provoking. Thank you, Dr. Arif, for stimulating us to think laterally and take care of our patients in a better fashion. Thank you very much.
Thank you, everyone.
Yeah, thank you, everyone.
Thank you.
I think Dr. Shanta will take over the next session. Dr. Shanta, welcome, Professor Gren. It's a very, very early morning to you. Good morning.
Thank you, Sushmita. Shall we go straight to the
Yes, please.
The first paper is by Dr. Harshita Kadava. So can we have her presentation?
Yeah, all of these are pre-recorded, so they'll be played. Just stick to time.
Will the questions be from the discussants only?
Yes, ma'am.
Oh.
If there's time permitting from the others, because there's
Hello,
4
everyone.
minutes.
The clinical challenge. Hello, everyone. The clinical challenge that I'm going to present today is a case of Klippel-Trenaunay syndrome with pupillary block glaucoma. Phacomatosis pigmentosa vascularis are a group of rare syndromes involving structures arising from embryonic ectoderm. It presently includes more than 30 different disorders. Following are the phacomatosis that have ocular association with various modes of inheritance. Klippel-Trenaunay syndrome has sporadic inheritance. Coming to the case details, a 5-month-old male child was brought by the mother to our institute with chief complaints of whitish appearance of black part of the left eye since 3 days after birth, associated with gradually increasing size of the left eye, areas of pink discoloration on different parts of the body, associated with swelling of toes of both feet. On torchlight examination, the right eye anterior segment was essentially normal. The left eye had corneal edema and digitally high intraocular pressure. The child also had capillary hemangiomas involving lateral aspects of both legs and feet, along with soft tissue hypertrophy, more on right side. A provisional diagnosis of Phacomatosis pigmentosa vascularis with left eye secondary developmental glaucoma was made, and the child was started on anti-glaucoma medication and scheduled for examination under anesthesia. However, the hemoglobin levels were very low and the parents refused blood transfusion or examination under sedation, and the child was started on oral iron supplementation. Klippel-Trenaunay syndrome is characterized by the clinical triad of cutaneous capillary malformations, venous abnormalities, and soft tissue hypertrophy. There are somatic mutations in PIK3CA gene in Klippel-Trenaunay syndrome, which leads to cellular overgrowth and dysregulation of mammalian target of rapamycin pathway. There is mesodermal abnormality in this condition, which leads to persistence of arteriovenous communications in the limb buds, which manifests itself as the clinical triad. Some serious systemic complications are associated with KTS, like pulmonary embolism and gastrointestinal bleeds. Anemia in the present case is thought to be caused by the bleeding of the ectasias within the capillary hemangiomas. Various ophthalmic manifestations of KTS have been described, the commonest being angiomas of the choroid and glaucoma. The ocular abnormalities are more common when the cutaneous angiomas involve the face. The possible mechanisms of glaucoma associated with phacomatosis are angle dysgenesis, raised episcleral venous pressure, melanocytosis of the trabecular meshwork, angle closure glaucoma, and premature aging of the trabecular meshwork. The glaucoma is usually intractable and requires surgery. Any invasive procedure can have the high risk of severe bleeding and expulsive choroidal hemorrhage. Coming back to our case, the child was brought back by the parents after 3 months with improved hemoglobin levels. However, the ocular as well as systemic manifestations have worsened. The axial length in the left eye increased from 18.6 to 25 millimeters in a span of 3 months. The child was immediately taken up for examination under anesthesia with a tentative plan of left eye combined trabeculotomy and trabeculectomy. The intraocular pressure in the left eye under anesthesia was 18 millimeters of mercury. However, on table, it was found out that the child had imperforate pupil with iris adherent to the cornea. Careful visco-dissection of the iridocorneal adhesions was done. Pupil was created with a 23-gauge vitrectomy cutter. A persistent tunica vasculosa lentis with a localized lenticular opacity was noted during surgery. On first postoperative day, the intraocular pressure in the left eye was 8 millimeters of mercury and retina was attached. The child was started on postoperative medication and was reviewed periodically. There et al. Have reported a case of Klippel-Trenaunay syndrome with persistent fetal vasculature and spontaneous hyphema. The present case had Klippel-Trenaunay syndrome with secondary glaucoma and persistent tunica vasculosa lentis. A combination of pupillary block glaucoma with a persistent tunica vasculosa lentis in Klippel-Trenaunay syndrome, to the best of our knowledge, has not been reported before. We have only had one other child who has presented to our institute with KTS and choroidal hemangiomas. So the two most important lessons learned from this case are that Klippel-Trenaunay syndrome can have an atypical presentation, that is without any facial hemangiomas and with pupillary block glaucoma, and delay in intervention must be avoided in such cases as glaucoma can progress very, very rapidly. Thank you.
Thank you, Dr. Rashita. Can we have questions from the discussants now?
That was a very well-presented case. Thank you for sharing it. Persistent fetal vasculature is fairly common. It's a common abnormality. And with this syndrome, the KTS syndrome, it's known that glaucoma can occur. Most cases of persistent fetal vasculature do not have any glaucoma. Are you sure that this patient had a pupillary block glaucoma and not a glaucoma associated with the syndrome itself, and just happened to have persistent fetal vasculature? Or was it clear that the patient actually had pupillary block glaucoma? Because again, we see many patients with persistent fetal vasculature who have synechia between the iris and the lens, and they don't have glaucoma. I'm not saying it can't happen. I've seen it happen once before, but it's very uncommon. So what about this possibility that the glaucoma was actually associated with the systemic disease as opposed to the localized persistent fetal vasculature?
Thank you, Dr. Arif, for that question. Yes, the glaucoma may not be because of the pupillary block is what we did not have that in mind before we took the child for examination under anesthesia. But once we took the child for EUA, we noticed that there was practically no pupil. It was just an imperforate pupil. So we had to arrive at the diagnosis of imperforate pupil that is leading to glaucoma in this case. And yes, there was persistent fetal vasculature with a subluxated lens also. So maybe that component is also contributing to the raised intraocular pressure.
So I guess there was Iris Bombay when you went in there. There was Iris
Yes,
Bombay.
yes, there was, yes.
Since the cornea was hazy, would the UBM help? Did you try to do UBM under anesthesia?
That would have been an excellent thing to do, but no, ma'am, we did not do an ultrasound by microscopy, no.
Okay.
Any other questions from Dr. Julie or Dr. Parivadini?
I have one question. Why wasn't a cyclophotocoagulation considered? Now, because you see the visual potential in this eye is extremely poor. So I mean, I don't know. I mean, could a cyclophotocoagulation have been a better option? It might have shrunk the eye a bit and made it cosmetically look a little better.
Yes, Dr. Vinay. So eventually what happened with this child is that postoperatively the axial length has reduced to some extent, and then this child eventually required the TSCPC. But now we have actually planned the child for keratoplasty. So I mean, we are being a little optimistic in this child. So we are hoping that there is some visual potential, and we want to see how it goes.
Dr. Brooks, would you like to comment on the diagnosis and management?
Yes, yeah, thank you. Sorry, I missed a little bit of that. It's an early start for me here, but thanks for the presentation. Obviously, there are multiple mechanisms here, and I think sort of my choice of things would be when there was such an anterior segment abnormality and a rapidly increasing axial length is to get the pressure down with, as I agree, with diode laser in the first instance. I think any other sort of surgical options like trabeculotomy, combined trabeculectomy probably have quite a low chance of controlling the pressure. And I also just would be a little bit cautious about the last comment about proceeding in a child of this age with a penetrating keratoplasty, particularly if they've got a fellow eye that has good vision, because I think the chance of a penetrating keratoplasty having a long-lasting effect and having any visual potential, from dense amblyopia, I think it may bring the child through quite an extensive period of treatment with very little effect on visual outcome. So I'd just be a bit cautious about that in the long run.
Thank you so much for all your comments. I think we don't have any more time for discussion. We'll go on to the next paper, Ocular Steroid-Induced Cushing Syndrome in a Baby.
My regards to everyone. Today I'll be speaking on a case of ocular steroid-induced Cushing syndrome in a baby. We have no financial interest to disclose. A 6-week-old boy presented to us with bilateral watering since birth. Parents gave history that right eye appeared larger than the left eye, and child also had photophobia. His birth history and family history was not significant. There was bilateral boophthalmos and bilateral cloudy cornea. Right cornea appeared more cloudy than the left cornea, and there was significant cupping of the optic disc. So he was started on brinzolamide 1% eye drop and was scheduled for examination under anesthesia and surgery. Under anesthesia, we noted that child had bilateral corneal haze. There was also presence of epithelial bedewing and posterior embryotoxin. On gonioscopy, high iris insertion was noted. His IOP was 12 and 6 when measured on Perkins tonometer. Axial length and cup disc ratio was significant for the age. So we made a diagnosis of primary congenital glaucoma in both the eyes, and child underwent bilateral goniotomy. Surgery went uneventful. On postoperative day 1, his IOP was distally normal. Both cornea was clear. There was no hyphema and no discharge. So he was started on topical betamethasone too early. Tobramycin and carboxymethylcellulose was also started. At his next follow-up at 2 weeks, his IOP was fine. Cornea was clear, there was no hyphema or discharge, sutures were intact with no suture infiltrate. So his betamethasone was decreased to 6 times and parents were advised to taper it further. When we followed child at 4 weeks, we were surprised to see that child has developed obesity. There was weight gain, moon faces, and also there was hirsutism and facial hairs. But his glaucoma was fine. with IOP under control and cornea was clear in both eyes. So we sent the child to pediatric endocrinology department, and they noted that child had grade 2 fatty liver with mild hepatomegaly. His serum ACTH and cortisol levels were also on the lower side, and these findings were consistent with exogenous Cushing syndrome. So he was started on maintenance dose of hydrocortisone 3 milligrams and was advised to give a stress dose of hydrocortisone before next UA. Meanwhile, we also got clinical exome sequencing report, and child was positive for USP11 gene mutation. At his next follow-up at 3 months, there was weight loss and moon phases started to settle. As we can see in the photographs, his serum ACTH and cortisol level became normal. Glaucoma was also controlled with IOP of 7.8 and 8.4 on eye care and bilateral clear cornea. At his last follow-up on post-operative 6 months, his moon phases further settled and hirsutism less. Glaucoma was fine with IOP of 9 and 8 and bilateral clear cornea. Now let's see how child fared during the post-operative course. Post-operative day 1 when he was pretty much normal. At 1 month when he developed Cushing syndrome. Post-operative day 3 months and further follow-up. We pondered over the fact that our child developed Cushing syndrome in post-operative course. So what might have gone wrong? Did we overdose or something else was there? We did our mathematics regarding how much steroid should be given to a child as per weight. So our child was 4 kg and the dose and the amount which we have given to the child was well within the safe limit. As already told, a child had USP11 gene mutation. We did some research and we found that USP8 gene is implicated in development of Cushing disease. USP8 and USP11 belongs to the same family. So per se USP11 has any direct role in development of Cushing, we don't know yet, but this needs further research. Now coming to our take home message, which is very important from this case, that a punctal occlusion is very important to prevent systemic absorption of any topical eye drop. We have to be very vigilant in all the babies, and if we are prescribing corticosteroid, it has to be properly dosed and it should be used very judiciously. And this child needs very close monitoring. Thank you, everyone.
Thank you for that excellent presentation. We now invite questions.
Thank you for the nice presentation. Can I just ask you a question? Did you take the history that the mother was, if the child was still breastfeeding and the mother was on some kind of oral steroids, that kind of led to the increase to accumulation of steroid in the child as well, and that could have been a possibility. So did you take that history?
Yeah, thank you for the question. We did actually. We asked all the possible factors which could have led to the Cushing syndrome, but there was no history. Like, am I audible?
Yes, you are.
Yeah. We asked all the possible history, like mother is taking any drugs, any other factors. Mother is putting any some local medication for skin and other illness. There is no as such history, so there was no other factors that could have caused Cushing disease in this child.
Yeah, at times, sometimes to even topical application of steroid in the patient due to any reason can also be an exogenous cause.
Yeah.
Thank you.
Any other questions or comments?
Can I make a comment? This is a very interesting case and great to be brought to awareness. Usually this situation is another specialty has been prescribing steroids and the patient comes with glaucoma. You have a patient who you treated for glaucoma and you gave steroids and they have a Cushing. I don't think anything was done wrong here. Whenever we give steroids to babies, it's such a high dose for them. The more common phenomenon that I think we all should be aware of is we're often suppressing choroidal endogenous steroid production in babies when we give them these drops. These drops are such a high concentration for babies. And we have to remember that when the drop goes in the eye, it bypasses the liver, so it's not metabolized. It's a direct dose. And babies also, skin is less protective, so that's another route that the steroid gets in. The more common situation is we cause sort of an adrenal suppression when we give steroids too much to these very young babies. And we should always try to minimize the steroids that we give as drops to babies. I don't think anything was done, quote unquote, wrong in this. There are just some patients who are more sensitive to it than others. So I think it's a very important thing to be brought to awareness. These drops, when we give drops of steroids to babies, it's a very, very high dose for them that does not get metabolized as it would if it were an oral or IV injection. Thank you.
Can I ask a question?
Sure.
Yes, ma'am.
Like some children are more sensitive for adrenal insufficiency. They have more chance of having adrenal insufficiency. And in children, sometimes there is long recovery time which can be associated, or maybe are there any predisposing factors, or are there any warning signs which leads you to think that this child can be oversensitive?
Ma'am, as such, there are no predisposing factors unless the child is systemically well. So, or the birth history and other history is non-significant. So it's just a what we can say a random case of Cushing which developed in a child out of the normal routine cases which we do. So as such, it's very tough to say that any predisposing factors can cause unless the systemically and history-wise child is normal.
Can I have a quick question to everyone for that matter? That whether we prefer betamethasone or prednisolone or loteprednol would fare better as a routine use in children, would that make any difference?
An answer to this is that in children, I think you need a lot of anti-inflammatory. So the betamethasone has a higher steroid-induced glaucoma potency and a greater anti-inflammatory effect. We prefer to give betamethasone at least for the first 2 or 3 weeks, because you need to control the inflammation very fast and very quick. And most of the other things like prednisolone or loteprednolol do not give the amount of anti-inflammatory effect which betamethasone does. But then going on to add to that is, I don't know how long you need a steroid after goniotomy. I mean, do we need steroids for such a long time after a simple goniotomy? I really don't know.
I think 4 weeks or so should be enough. And also I personally use prednisolone for majority of my pediatric cases, whether it is a trab or tube or even a goniotomy. So,
So I think the thing about prednisolone is that it's a suspension, and if the parents don't shake it enough, they might not be, and it's sort of itchy, it's a little more itchy, and the children don't tolerate it. That's just one reason, but I think potency-wise it should be all right. But betamethasone is easily available, cheap, so that's what.
Sure.
Can I ask a question?
Yeah, go ahead, but this has to be the last question because.
Yes, ma'am. No, very interesting case. But what I wanted to know is, going forward, if this child requires another surgery, so how do we prevent a Cushing manifestation in the future?
Yeah, we have to be vigilant in this case, especially. So we have to take care. We have to have a closer follow-up of the child. We'll titrate. We'll monitor with ACTH and cortisol level, especially in this child. We'll keep APC pediatric team under our hold just to monitor the child systemically. That any manifestation like this child has fatty liver and other manifestations. So we have to keep a watch of the cortisol levels, ACTH level, and other system Cushing syndrome. And from steroid point of view, we have to have a frequent follow-up, closer follow-up, and we should start titrating steroid faster than the usual child. Yeah.
Thank you for your answer. I think we'll move on to the next paper, Complex Management of a Case of Unclassified AR Syndrome by Dr. Jolie.
A very good morning to all of you. Today in this presentation, I'll be discussing the management of a case of unclassified axon-filled Rieger syndrome
A 25-year-old male residing in Bareilly complained of blurring of vision in both the eyes with a gradual increase in the whiteness of the eyes, left eye more than right eyes, in the last 4 years. On examination, the vision in the right eye was 6/60 and counting finger close to face in the left eye with a high myopic refractive correction. Intraocular pressure was 38 millimeters of mercury in the right eye and 28 millimeters mercury in the left eye. On examination, both the eyes had large corneal diameters. On closer look, the right eye had posterior embryotopsone, extensive iridocorneal adhesions temporally, and a stub of iris present nasally, and the cornea had a steamy appearance. Further examination revealed a defect in the posterior cornea surrounded by corneal opacity. However, there was no iris attachment noted in this area. The limbus also appeared stretched, particularly in the superior area. The left eye examination revealed dense corneal scarring and 2 flaps of Descemet's membrane detachment extending from 12 o'clock to 3 and 9 o'clock. The eye had aniridia with a stub of iris present temporally. Systemic examination revealed maxillary hypoplasia, micro and hypodermia, and a redundant umbilical skin. When we looked at his childhood photographs when he was 10 years old, the cornea in both eyes appeared clear with no evidence of enlarged corneal diameter. B scan done on the day of presentation showed axial length of 25.8 mm in right eye and 27.2 mm in left eye. Based on our clinical features, our differential diagnosis were either unclassified exenfil Rieger syndrome or Peters anomaly type 1 or a subgroup of keratoideal lenticular adhesions. What did not fit into the KILD group was that the corneal opacity was not present during childhood. The points in favor of atypical or unclassified exenfil Rieger syndrome were the presence of ophthalmos, dense corneal opacity with edema, defects in posterior stroma, Descemet's membrane detachment, aniridia, and extensive iridocorneal adhesions. So a diagnosis of both eyes unclassified exenfil Rieger syndrome with ophthalmos with spontaneous Descemet's detachment and pathological myopia was made. The patient was started on topical and systemic anti-glaucoma medications, following which the cornea in the right eye cleared slightly with vision improving to 6/24. The right eye IOP was 22 and left eye IOP was 18. In view of the dense corneal scar in the left eye, a penetrating keratoplasty was done in February 2019, following which the vision in the left eye improved to 6/36. Histopathological examination of the left eye corneal button showed stromal scarring, edema, and mild acute and chronic and non-specific inflammatory cell reaction. However, the intraocular pressures were uncontrolled in both the eyes on maximum medical treatment, so an AGV implant surgery was done in the left eye on 24th of June 2019, followed by the right eye surgery. The tube of the AGV was well placed in the sulcus. These are the pre and the post-operative pictures of the left eye. The vision is maintained at 6/36. The cornea cleared markedly in the right eye following surgery, with vision improving to 6/24 and intraocular pressure of 14 mm of mercury. The most common genes involved in exenfil Rieger syndrome are PTEX2 and FOXY1. There have been rare reports of cases where the exenfil Rieger syndrome or anomaly was associated with aniridia, and a PTEX2 mutation was found in those cases. A number of genes involved in the various anterior segment dysgenesis overlap, and thus giving rise to overlapping phenotype, and thus the immense variability in clinical pictures in these patients. In this case of ARS with bilateral congenital glaucoma, the CYP1B1 mutation was found to be the causative agent instead of PTEX2 gene. In the family tree of a patient, none of the family members was found to have similar ocular disorder. Medical exome sequencing covering 17,000 medically relevant genes was done in a patient. A mutant allele in the MFRP gene was identified. The MFRP gene encodes a type 2 transmembrane protein. The MFRP gene plays a crucial role in ocular development and has been found to be associated with conditions such as nanophthalmos, posterior microphthalmia, retinitis pigmentosa, foveus caesis, and optic discruscent. No current research study has suggested the segregation of MFRP mutations to the ARS phenotype. Also, in this case, as a mutation is present in heterozygous form and is causing no change in protein structure function, it is less likely to be the cause of the condition for the patient. So the probable cause could be due to the presence of interstitial single or multi-exon gene deletion duplications, splice site variants, intronic variants, variants in promoter or enhancer regions, or chromosomal rearrangements which could not be analyzed. So though clinical classification is straightforward, the genetic classification is increasingly complex due to intricate developmental genetics and embryology of the anterior segment.
Thank you. The session is open for questions now from our discussants. Very challenging case indeed.
It's a very interesting case, and thanks for putting it together. It's quite complicated. It's great that you had the old photos of the patient. I would just label something a little bit differently. I would think that this patient had large eyes related to pathologic myopia. I don't think it's buphthalmos. If he didn't have it during infancy, he didn't have glaucoma during infancy to induce ocular enlargement, then if he's getting globe enlargement later, I think it's more likely he has a pathologic myopia. I wouldn't consider it to be secondary to the increased intraocular pressure. That's only one thing I would say differently about the patient. But, these patients are like snowflakes. They say that no two snowflakes are exactly alike. And, we just have to describe what we see. Sometimes it fits into categories where we have terms for them, but sometimes it doesn't. And sometimes we find a genetic cause and sometimes we don't. So this is real life. And thanks for presenting it.
Thank you, sir.
Thanks. Can I ask a question?
Please do.
Yeah, thank you. I'm just interested in the tube surgery, and I think the tube surgery is obviously the thing that would have the most beneficial effect in controlling glaucoma. One of the biggest risk factors for graft failure is uncontrolled glaucoma. Did you ever consider doing the tube implant before the graft? And what was the control of the glaucoma pre-penetrating keratoplasty?
Yes, sir. So the corneal scarring in the left eye was pretty dense. So only in slit lamp evaluation in oblique illumination that you could identify the angle structures, the intersegment structures, just visible. But for tube implant surgery, I think more visibility was required. And during the penetrating keratoplasty surgery, the intraocular pressure was fairly controlled with systemic and topical agents. So the corneal surgeon went ahead with the penetrating keratoplasty first, so to maintain some visibility.
Thank you.
Any other comments about the surgical management? Could diode cyclophotocoagulation have been attempted first before the penetrating keratoplasty was done, since visibility was an issue?
Yeah, so it was in discussion with the cornea team that we felt that because the intraocular pressure was fairly controlled and the operation was done under general anesthesia. So during the penetrating keratoplasty procedure, the general anesthesia was deepened. So in order to get a good control of the intraocular pressure, and that is how it was planned. Yeah, yes, but surely a PACPC procedure would have been the second option.
How about the combined keratoplasty along with shunt? Could we consider that in this particular situation?
In that scenario, actually, post-operatively, we don't really know how much hypotony the implant surgery is going to cause, because in penetrating keratoplasty, the suture tightness is very important so that it doesn't get loosened, so that titration is not very easy to make. So when you're doing the combined surgeries together, so I personally like the stepwise procedure in order to get a good idea as to what one procedure is doing, how much the cornea is clearing, and then take the second step of what should be the next step.
We have time for one more question.
To Dr. Arif sir's question, I would like to say that we were also a little amazed at how could the cornea grow after the age of 10 years. I mean, that was also quite, it was a mystery to us also. In pathological myopia, we can expect that the globe enlargement is there, but the cornea also enlarged with stretching, so that was a little very unusual.
Could it have been ectasia?
It was there was global enlargement of the cornea, like the corneal diameter was more than 14, and the detachment as well. Maybe that happened because of the enlargement of the cornea. So that was one thing that is still a mystery to us. That how did the cornea enlarge so much, after the age of 10 years, where usually it does not happen.
Thank you.
Can I comment?
Just the last one, please.
I feel that the photographs that were shown, there was some element of corneal enlargement in those photographs also. I assume that you've not examined the patient personally. It's only by the means of photographs.
Right.
The descendant membrane detachment could actually be due to Harp's stria in that patient if he presented in the early childhood. With these patients may not progress so severely compared to PCG patients. So it could be that it was an early onset glaucoma only in this patient with late presentation.
Probably.
Thank you. I think we'll go on to the next paper now. Managing bilateral malignant glaucoma in a young girl, Dr. Monica Arora.
Good morning, everyone. I am presenting a challenging case, managing bilateral malignant glaucoma in a young girl. 16-year-old female presented to us with the blurring of vision in left eye for 2 months, which was sudden in onset, associated with severe eye pain and redness with intense headache. The patient was diagnosed with both eye primary angle closure glaucoma and underwent both eye laser peripheral iodopy. The patient underwent left eye trabeculectomy with 0.02% mitomycin C under local anesthesia. There was no significant family history. An ocular examination shows visual acuity in right eye 6/6, whereas in left eye 6/9 with -1 diopter spherical. The best corrected visual acuity was 6/6. The clinical picture of right eye shows patent peripheral iodotomy, whereas in left eye shows inferior iridocorneal touch with borderline intraocular pressure 22 mm of mercury. On gonioscopy, both the eyes were having occludable angle with patent ostium in left eye. Biometry reveals axial length in right eye 21.70 and in left eye 21.75 mm. The anterior chamber depth in right eye was 2.59 mm and in left eye it was 2.80 mm. The vertical CDR in right eye is 0.7 with inferior notch, whereas in left eye it's 0.8 with pale rim with inferior notch. HVF 30-2 reveals right eye paracentral scotoma, whereas in left eye superior arcuate with inferior nasal step. Now coming towards the management. Patient underwent left eye AC reformation with sodium hyaluronate. Post-operatively, AC was formed but shallow with controlled IOP 12 mm of mercury in both the eyes with visual acuity 6/6. On follow-up, the right eye intraocular pressure was high, therefore the patient underwent right eye trabeculectomy with 0.02% mitomycin C. On 2 weeks follow-up, both eyes were having high intraocular pressure with shallow anterior chamber, as we can see from the clinical picture. Therefore, the diagnosis was made both eye malignant glaucoma and the patient was started on hyperosmotic agents and eye ointment atropine 1% QID. Multiple measures and interventions were done to preserve the lens and to overcome the condition. Different modalities were considered like medical therapy, AC reformation with air, Helon, single port transconjunctival vitrectomy with hyalotectomy were done. However, the condition was refractory to the above mentioned measure. Therefore, initially left eye was planned for clear lens extraction with IOL combined with single port transconjunctival vitrectomy with hyalotectomy with central posterior capsulotomy, and the patient responded well to this intervention. Subsequently, the right eye was also planned for the same procedure. Post-operatively, the anterior chamber was well formed in both the eyes with intraocular pressure 16 mm of mercury with visual acuity 6/6. Patient was started on atropine eye ointment 1% HS with steroid antibiotic combination eye drop 6 times in a day, which was tapered weekly. So, the summary of a case is both eye primary angle closure glaucoma in young
with plateau iris with operated trabeculectomy. Post-trabeculectomy, recurrent shallow anterior chamber with high IOP despite filtering bleb, suggestive of malignant glaucoma. Management: both eye clear lens extraction with IOL combined with single port transconjunctival vitrectomy with hyalodectomy with posterior capsulotomy. Thank you.
Thank you for the excellent presentation. Very challenging case. I now invite comments. I'm sure all of us have faced patients like this. So
do we have the lens dimensions of this patient?
Yes, ma'am.
And what was the lens thickness, the equatorial diameter?
Ma'am, the lens thickness in the right eye was 3.80, whereas in the left eye, it was 3.73, ma'am.
The equatorial diameter?
Sorry, ma'am?
The diameter of the lens, was it available?
Ma'am, it was plus 21.5, ma'am, diameter, ma'am. We have taken the lens, ma'am.
No. The crystalline lens, the diameter of the lens. Sometimes these young patients, when they present with angle closure, the lens is usually the cause. The lens can be a little smaller in size. Can you hear me?
yes, we can hear you.
Yeah. So that is the cause. So these eyes, when we do trabeculectomy, there is a forward movement of the lens and shallowing of the anterior chamber. So doing a pars plana vitrectomy usually helps in forming the anterior chamber in such eyes. That's why I wanted the equatorial lens diameter.
So it was, can I answer this?
Sure.
Yeah, sure.
It was not a case of microspherophakia. We do not do equatorial lens diameters usually unless we suspect microspherophakia because the anterior chamber depth was stable. So it was not lens induced per se. It was plateau iris leading to angle closure glaucoma in this patient.
Can I ask a question? So what was the lens vault, anterior lens vault?
Lens, hello, my voice is there. Am I audible?
Yes,
Yes, you
you're
are.
audible. Please go ahead.
The lens vault was 0.5 millimeter.
Okay, so it was very normal limits?
Yes.
Sometimes the lens vault is so anterior that, if you're doing trabeculectomy, you anyway have a less space in the anterior chamber. So any kind of overfiltration can lead to this kind of malignant glaucomas.
Any comments about the management of using Helon to form the anterior chamber in the case of a suspected malignant glaucoma?
May I have a comment? That's a very interesting case. We followed some of those young ladies many years ago when vitrectomy was not so common as it is today for these cases. And we were quite surprised to have a good follow-up with iridectomy plus atropine. So in some cases, probably you don't need to remove the lens because the using atropine for ciliary relaxation may help sufficiently in some borderline cases at least. So that is an old observation nowadays. Of course, with vitrectomy techniques, it's easier to proceed as you did it so successfully. Thank you.
Any other comments?
So you did, it happened after trabeculectomy. You did one eye first and then the other eye. So what precautions did you take while performing trabeculectomy of the other eye to prevent, can you prevent it? And
Yes, ma'am. We can we can take the releasable sutures and form the anterior chamber with high viscoelastic so that the post-operatively AC doesn't shallow, ma'am. And the iris and ciliary body remains at its anatomical position, though it doesn't come forward, ma'am, if the AC is formed, ma'am.
did you take any precaution because it happened in the it happened in one eye first and then you did the other eye? I missed something or?
Ma'am, laser peripheral iodotomy was done for the occludable angle and
yes,
atropine eye ointment was started preoperatively, ma'am.
Okay.
I would be a little hesitant to use Helon during the surgery. I agree with you that tight sutures, releasable sutures, using a cycloplegic preoperatively and postoperatively would be important, and keep a close watch to look out for the development of malignant glaucoma, because we use a viscoelastic like Helon, you could get very high intraocular pressures in the immediate postoperative period.
I think one of the important points here was the fact that there was a plateau iris in this young girl. And, you know, plateau iris really predisposes to malignant glaucoma. And often we do not do a gonioscopy or we miss plateau iris. But I think there's only one paper to suggest that plateau iris itself is a predisposing cause for malignant glaucoma, even in adults. So I think that was something which was very important.
Thank you, Dr. Vinay. Shall we go on to the next paper now? A new technique for glaucoma drainage device revision by Dr. Kirsten.
Hello, my name is Kirsten De Silva, and today I'll be discussing a new technique for glaucoma drainage device revision. I have no financial disclosures. Glaucoma drainage devices are often indicated in refractory pediatric glaucoma, typically following failed angle surgery or trabeculectomy.
We have lost the presentation.
Exposure with secondary endophthalmitis necessitates surgical revision. Methods of revision often include invasive techniques such as excision of the fibrous capsule, implantation of an additional tube shunt, or cyclodestructive procedures, and these provide only modest improvement of IOP and pose the risk of further complications. We describe a minimally invasive technique of GDD revision that may restore device function and lead to long-term improvement of IOP. We present a case of a 6-year-old male with primary congenital glaucoma. He had a left barbell implant placed in January 2018, and due to corneal contact with the tube, an elevated IOP, revision of the shunt was indicated, and surgery was performed in April 2021 using this novel technique. The invasive technique of GDD revision that may restore device function and lead to long-term improvement of IOP. We present a case of a 6-year-old male with primary congenital glaucoma. He had a left barbell implant placed in January 2018, and due to corneal contact with the tube, an elevated IOP, revision of the shunt was indicated, and surgery was performed in April 2021 using this novel technique. First, we dissected the conjunctival and tenon tissue overlying the tube using a Westcott scissors. We then externalized the tube through the scleral tract made during the previous surgery. The tube is then threaded or probed using a 4-0 Prolene suture and advanced into the bleb space, breaching any obstructions along its path. Here, we can visualize the position of the suture inside the bleb, and once there is no resistance, it is then removed from the tube. Using a 30-gauge cannula filled with balanced salt solution, the tube is flushed forcefully. This causes microfracture of the bleb capsule and expansion of the bleb, as seen in clip C. The tube is then redirected into the anterior chamber through a new sclerotomy to prevent corneal touch. In cases where tube length is the sole issue causing corneal touch, a single stab incision is sufficient. The tube is then externalized and can be trimmed, probed, and irrigated and reposed into the AC. A corneal patch graft is used to cover the tube, and the conjunctiva is closed using a vicryl suture. Our patient's preoperative IOP of 37 millimeters of mercury improved to 19 millimeters of mercury at the 7-month postoperative visit, and he has not required any additional surgery. In conclusion, performing additional invasive surgery on an eye that is already predisposed to a fibrotic healing response may be the only option in many cases. However, less invasive surgical approaches to restoring function of a failed tube shunt are preferred when possible. In pediatric patients with a previous GDD surgery, utilizing the technique of probing and irrigation of the tube may lead to restoration of GDD function with minimal inflammatory impact and long-term improvement in IOP, reducing the need for further invasive surgery. Thank you.
Thank you, Dr. Kirsten. That was, again, a very challenging situation. Any comments from the discussants?
Yeah, a very interesting way of dealing with the difficult situation, Dr. Christine. Thanks for presenting. I wanted to ask, do you have any criteria based on, say, how much is the thickness of the capsule around or anything of that sort that indicates that this particular technique to be used or any other alternative method to be used to open up the pathway or the tube?
Hi, thank you for that question. I will start by saying that I'm not an ophthalmologist. I'm an aspiring ophthalmologist, so I didn't perform the surgery. So I definitely will ask Drs. Vitrian and Dr. Krajewski that question. But I know that in speaking with them, anytime that they go to do a revision of this, the surgery, and in this case, the child had corneal touch, it is always a good opportunity to do this flushing and probing of the tube just in case, just to make sure that the tube is patent and the bleb is functioning. But that's a good question I will ask. Thank you.
Thank you.
May I ask about the possibility to use mitomycin in flushing back? Because most of these capsules are very dense. And finally, it's a question of how much obstruction or how much outflow resistance is present. And if we use some mitomycin, there might be an increased chance to use this technique.
Okay. I haven't read about using mitomycin to flush, but I have read about viscoelastic. But that's a good point. Can use mitomycin. I will ask that question as well. Thank you.
Any other comments?
Yeah, nice video. Did I miss that you did a tube revision because the tube was touching the cornea, or the tube was blocked, or there was a hypertensive phase that you had?
So there was an elevated IOP, but there was also corneal touch from the tube. So both things were happening simultaneously.
That the corneal touch was causing the high intraocular pressure, or the tube was partially patent, or was it just a minor touch?
I think it was just a minor touch, but it could have been that causing the high intraocular pressure as well.
Yeah, if the tube is patent, then one of the cause of a high intraocular pressure in an implant surgery is also a thick tenon cyst that forms over the plate that can restrict the aqueous outflow.
Okay, thank you.
So can I make a comment?
Please do.
So we can actually do intracameral flushing of the tube without even opening the conjunctiva. So in case we know that the tube is blocked, so that can be done intracamerally, and it's just about to be it's published in IGO. It will be appearing in 1 or 2 months. So that can also be tried. It's totally minimally invasive in that way.
Thank you.
I guess that could not be done in this situation because one of the reasons was to reposition the tube, wasn't it?
Yes, correct.
It's a little unlikely that the tube corneal touch would have been responsible for the elevated IOP. So I agree with Dr. Julie that it could be a hypertensive phase. Any other comments? We have another minute, after which we need to close the session.
Okay, so once you flush the tube and you reposition the tube, the pressures are controlled without any anti-glaucoma medications, or you did have to put the patient on AGMs?
So the patient was previously on COSOT and was maintained on that afterwards.
Okay.
So thank you to all the speakers. If there are no more questions, we close this session. And I think we need about 5 minutes for Dr. Sushmita to look at the scorecard. Meanwhile, Dr. Vinay, would you like to start a discussion on any questions that...
I think it was Dr. Khan's talk that had invited a lot of questions, and a lot of them could still be asked and answered. For example, Dr. Khan, for example.
I actually have questions about
the
presentation of Dr. Gupta.
Yes.
A lot of comments about that.
Yeah, sure. Go ahead, please.
I thought that was an excellent presentation and so many points from it. I think you mentioned in the very beginning, a very minor point, you said something, FOXC1 represented 2% of your cases and you didn't find it to be autosomal dominant, is that correct?
Yes, most of the cases in our setup are sporadic, with parents are not involved.
I would just like to say there are two possibilities for that. One is that obviously it's a new mutation in the child, because the mutation has to start somewhere and it's still autosomal dominant. It's just starting in the child. The other is sometimes the parents have a mutation in the gonad, in the sperm or the egg. It's known as gonadal mosaicism. And it seems like it's a new mutation in the child, but actually one of the parents is carrying the mutation in either the testes or in the ovum. And it's not in the soma, so they don't manifest the disease. However, there's still a risk of transmission of having additional children. So I just wanted to mention that that's always a possibility when you find the mutation in a child, but not in one of the parents. It's either a new mutation or it's the phenomenon of germline mosaicism.
So how do we find the germline mosaicism in the parents? How do we go about
That's
it?
a whole different topic. And usually, it's very underdiagnosed, and it's usually not suspected until they have another child with the disease. So that's a whole different topic, but there are ways to do that. They're a bit invasive. But actually, it's often assumed if you have a patient, for example, if one of those families you had that was sporadic, if that same family had another child with FOXC1 mutation, there are basically two possibilities. One is that there's germline mosaicism, or that the parent is not who we really think it is, which happens sometimes. So the other things, in the past, we used to do a lot of targeted testing and we found mutations, and mutations were causing this or that. But now, as you're doing, in your center, we're doing more of these whole exome and whole genome analyses, and we're uncovering many gene mutations in addition to what was considered to be the primary cause. And it's very nice, but it's very confusing also, because we find all of these quote unquote mutations that people are heterozygous for, carriers for, that may have nothing to do with the phenotype, or they may have something to do with it. And it's just, I think now our bottleneck is not the technology. We have this technology now, it's not expensive. The bottleneck is interpreting it. The interpretation is really difficult with all of this data, but we're uncovering a lot of interesting things, and you are uncovering a lot of interesting things now that we're
talking about we will have to keep talking to you and to others who are doing genetic testing to understand better and to be able to help about whether these genetic mutations are actually pathogenic or not.
You mentioned, okay, go ahead.
So you speak first.
You mentioned the Cpamd8 gene in your talk, and that gene has been described as a cause of primary congenital glaucoma. But I would say that when you go back and look at these patients more carefully, there are subtle iris abnormalities, there's subtle corneal abnormalities that are primary. So it's true, it's a developmental glaucoma. Mutations in that gene cause a developmental glaucoma, but it's really not primary congenital glaucoma. It's really congenital glaucoma with anterior segment dysgenesis. And for example, another one is FOXC1. FOXC1 has been described as rarely causing congenital glaucoma. But if you go back and look at those patients, often you see a little bit of chlorectopia. You see a posterior embrotoxin that wasn't looked at previously. My point is that these additional genes that we associate with anterior segment dysgenesis, sometimes they're being said to cause, when mutated, to cause primary congenital glaucoma. But when we go back and look at those patients, there are subtle anterior segment findings that might have been missed or might have been attributed to prior surgery. So that's another point I wanted to make when you mentioned that Cpamd8.
Yes, sir, that's true.
And I'll say one final thing. You mentioned about how do we define Axenfeld-Rieger syndrome, exospectrum, all of this. And I think you hit on a very crucial point. What we really should be doing, what we're moving towards, is describing phenotypically what we see and then associating the gene. For example, PAX6-related aniridia, CYP1B1-related aniridia, FOXC1-related aniridia. These are all different conditions. Rather than just calling it aniridia, when you add the gene, you know what you might also have to suspect in the future or not worry about in the future with the example of PAX6. If you know it's not PAX6, you don't have to worry about this risk of Wilms tumor Wagger in a new case. So it was really, I thought, so many points in that presentation, and thanks for taking all of this on and presenting it.
Thank you, sir, for your great inputs. I also have a question. Do you come across Axenfeld-Rieger syndrome patients or other anterior segment dysgenesis, which are like auto-regressed? For example, a case which was presented by Dr. Julie also today. It looked like an auto-regress kind of an ARS, which again manifested high pressures later on in life. So we have been seeing some patients like 3 or 4 now, which have HARP striae and enlarged corneal diameters, but on follow-up, they are having, totally normal IOPs. So that is also a thing that needs to be looked at. So have you encountered such cases in your practice?
So you're saying, I'm not sure exactly what you're asking, but I think what you're saying is patients who spontaneously regressed, or yes, patients who had abnormalities and didn't have glaucoma initially and develop it later.
I'm saying that they have some manifestations of high pressures in childhood, like ophthalmos and HARP striae, but now on follow-up, even we are seeing infants with ophthalmos and HARP striae with normal pressures now and normal findings on follow-up. So we have done prophylactic goniotomies in 1 or 2 patients, but we're not really sure what we are dealing with.
Well, there are many different explanations. One is that, ophthalmos actually is a release. It's like blowing up a balloon. And actually, once the eye is expanded, that's actually the body trying to take care of itself. Sometimes that's enough to stop progressive cupping. So that's one possibility. Another is that, as somebody mentioned in the meeting, I don't remember exactly who it was, you can have a progressive glaucoma even if the pressure on it, quote unquote, is measuring normally. So that's another thing we have to worry about. Finally, you can have some patients who actually do spontaneously improve, get better. This is uncommon. That's a rule out diagnosis. You have to rule everything out first. But I would say those are the 3 categories of things that could explain this. There's so much variable expressivity in these patients. It's really, we continue to learn from them as we discuss in meetings like this.
Yes, sir.
Can I just make a quick comment, please?
Yes, ma'am.
Yeah, I think we had patients like this. What we realized at that point of time was, if you do the gonioscopy, if there is a dysgenesis, probably you can label it as a spontaneous resolution of developmental glaucoma. Otherwise, it's not very common in India where there is a misuse of the topical steroids or whatever form of the steroids. At one point of time, when the child is small, the pressure would have raised that have resulted in features very characteristic of developmental glaucoma. Gonioscopy may help to certain extent differentiating the two.
And all three patients of ours had some features of ARS in the iris.
Okay, sorry, I think I missed that part.
Yes.
I just want to add that, sorry.
Yes, sir.
I just want to add that we observed similar cases. That was something where the girl, the child was diagnosed with Axenfeld-Rieger's, and then the parents were looked upon and they weren't aware that they had glaucoma, and one of those had, as you described it, has HARP striae and normal pressure and some excavation of the disc. So we interpreted that as some kind of self-healing, like Dr. Khan said, that stretching or whatever can, but also the development of trabecular meshwork is not finished at time of birth, and there may be additional ripening, additional maturation of trabecular meshwork later that will settle the disease. Yeah. So there are two cases that we published many years ago.
Thank you. Thank you.
Shika, I just wanted to add that we had a couple of cases like this where there was spontaneous detachment of Schwab's line, along with which the iris adhesions also detached. So it's possible that in that patient, typically like what you described, enlarged corneal diameter, HARP striae, but pressures were under control. And that boy developed glaucoma when he was 13 or 14 years old.
Yes.
So at a later time point. So possibly that spontaneous resolution can occur, especially when you have detached Schwab's line and maybe the synechia and partially the angle starts from. That's a possibility, especially in Axenfeld-Rieger.
Yes.
You want me to announce it, is it? You go ahead.
Dr. Khan, we have almost like 50 such families of Axenfeld-Rieger's where we have phenotyped the parents very carefully. And in almost 80% of them, the parents do not show any features of Axenfeld-Rieger's. So so is it possible that in our population, the gonadal mosaicism that you talked about is the one that we need to look for, because we don't find an autosomal dominant inheritance at all. In fact, very rare.
But do you have a mutation in the children?
The children, yeah. So interestingly, the children, I would say, almost always had a FOXY1 or CYP1B1 mutation.
Okay, well, a single CYP1B1 mutation wouldn't explain the phenotype if it's just heterozygous. But if they have FOXY1, I don't know how large these families are. They're either new mutations, if it's deemed to be pathogenic, or gonadal mosaicism, for sure.
Right. Or could it be an environmental effect leading to the gonadal mosaicism?
I mean, did you test the ones who had the FOXY1? Did the parents also have the FOXY1 variant?
The parents did not have it.
They didn't have it. Okay. Yeah. So.
Yeah, it's very strange. So now we are actually looking at some environmental effects because majority of our parents are unaffected.
When you say unaffected, they don't have this is in the context of having a mutation in the child, a convincing mutation in the child. Yeah.
True. Yeah.
Is it? I'm asking.
Yes, it is. It is. The parents, the child does have FOXY1, but the parents don't have it.
So it's either new or it's gonadal mosaicism.
Yeah. Yeah.
So I'm ready with the results whenever you are.
Yeah, please go ahead, Sushmita.
Yeah. So of course, it makes me extremely happy that yesterday's free papers, as Gauri said, was almost impossible to score all of them because they were all so good. But easily across the board, the winner was Dr. Sandeep Chaudhary for newborn glaucoma due to rubella. And in today's session for clinical challenges, Ashok was a unanimous winner for Cushing syndrome. So congratulations, Sandeep, and congratulations, Ashok. You would be getting your certificate soon. And of course, all of us will be getting our certificates too. And I think that brings us to the close. And I'm happy to have Sirisha offer the vote of thanks, if at all, and then we'll move on. I think all of us can have our cameras on, then we can have one picture probably of if all of us have our cameras on right now. So Sandeep is in. Congratulations, Sandeep. And I think Ashok is in as well. Congratulations,
Thank you, ma'am.
Ashok, from all of us.
Thank you, ma'am.
Congratulations again for all the winners. Wonderful 2 days. I would like to really appreciate all the effort that has been put in. Sushmita, hats off. Wonderful, wonderful way you have pulled it off, and the team has done a great job. So a big thank you for all the keynote speakers, wonderful talks, and today's were the highlights. The panelists did a fantastic job. The moderators really, really took it on, and everything was on time and very interesting. I think the questions could go on and on. So we only have so much of time. So thank you so much again for the delegates for active participation. Thanks to MTOD for the generous support, the AV team, and the organizing group. So Vinay, Dr. Mandal, all of them, thank you so much for your suggestions and help all throughout. Thanks again, and we look forward to welcoming you in a physical meeting in the next year.
Thank you.
Thank you so much.
Thank you.
Thank you. Thank you, everyone.
Thank you. Thanks a lot. Thanks.
Yeah, thank you, ma'am. Thanks for a great meeting.
Thanks
Thank
a
you.
lot.
Thank you,
everybody.
Thank you, everyone.
Thank you.
So I think the members have a separate link for the GBM. So the GBM will be followed up right now. You can log in.